I want to thank the AAPRAS, Yerevan State University, Dr. Armin Hovhannissian, Dr. Gilbert Georgian, and the rest of the organizing committee for inviting me today to speak about facial paralysis reconstruction. This is an area that I have specialized in for many years and have continued to do the bulk of my research in. So without further ado, let us begin. Facial paralysis is very simply damage to the facial nerve. There are various ways to describe it: partial versus total, unilateral, bilateral, acute, chronic, congenital, acquired. It is essentially dysfunction of the facial nerve, and in its pathway from the brainstem, it does pass through the stylomastoid foramen and into the parotid gland, where it significantly arborizes and enters the facial muscles. There's in total approximately 20 muscles responsible for facial expression and are innervated by the 7th cranial nerve, and they are responsible for very key functions, functions such as eye closure or lip closure, speech, articulation, swallowing, smiling. These are very prominent parts of the human existence. Causes of facial paralysis are many. The most prominent one here in the United States is more commonly referred to as Bell's palsy. It's an inflammation-mediated, believed to be virally induced phenomenon, which results in a neuropraxia of the facial nerve, which can sometimes be permanent in some cases. Other more focal reasons include trauma, stroke, a tumor, congenital agenesis of the nucleus of the cranial nerve, and in many cases it is idiopathic. The problems of facial paralysis are very obvious and are very visible. They include brow or eyelid droop, an entire facial droop, facial asymmetry, and even smile asymmetry, dynamic losses such as that. This translates into various problems, and some of them are very real and need to be solved. Some things like eye protection, and the ability to close the eye and protect the cornea, is a very important feature of the facial muscles. Speech disturbance can occur due to articulation problems, drooling, swallowing problems. Inability to close the lips causes dental caries and drying of teeth. Psychosocial problems are obviously the most common reason why patients seek treatment. Here I wanted to outline what a very critical part of facial paralysis intervention entails. A very clear distinction that needs to be made: or is this early or is this late paralysis? In early paralysis, here I'm defining it as less than 12 months. We're really talking about how the neuromuscular end plates are still attached and are very much intact and can be re-innervated through nerve transfers. Whereas in the late case, there's permanent denervation or permanent loss of these motor end plates, and muscle or nerve transfers cannot be performed with any, muscle transfers can be performed with reliability, but nerve transfers cannot be. So to wait or not to wait? So this is very controversial. At what point do you intervene in the early setting? The classic teaching is you wait for nerve regeneration to occur, especially in the setting of idiopathic or, the idiopathic facial nerve paralysis. But this is problematic. When you decide when it's time to intervene. And the very easy answer to that is that you need to follow a trend. If there is a portion of the trend that results in non-progress, then that needs to be identified and addressed. And of course, early treatment is always a better option. So in determining diagnostic or the reasons for facial nerve paralysis, it's very important to obtain certain initial diagnostic studies, including a brain MRI to rule out any cerebral tumors. Nerve conduction studies and EMGs are possible and can identify the type of denervation and the level of denervation, but they do not necessarily tell us much about facial symmetry or about facial movement. What is the external result of the facial paralysis? And this is really the reason to intervene. And in my practice, I institute very strict periodic physical exams that identify and evaluate the facial paralysis at every step. And in a special circumstance, congenital palsy is a situation where the facial nerve nucleus failed to develop, or the facial nerve itself failed to develop, in which case there's no real potential for nerve regeneration to occur. So waiting it out or trying to do even a nerve transfer is a foolhardy venture. Things such as Mobius syndrome and hemifacial microsomia are common representatives of this type of condition. And it's really the surgical options, the muscle transfers, that are the only real solution in this case. So treatment is, like I mentioned before, mostly and largely related to a simple observation in most cases, whether it's post-surgical facial paralysis or it is the result of Bell's palsy. A simple observatory period is very much practiced across the board. Steroids and antivirals are given in the setting of a suspected Bell's palsy, where a virally mediated nerve paralysis is suspected. And in my practice, I tend to escalate the level of treatment or heighten my level of intervention if there's no improvement at 3 months. So how do we break down early versus late treatments? Early treatments really deal with nerve transfers. We're talking about masseter to, we're really talking about facial nerve analogs that are transferred into the facial nerve trunk or the branch of the facial nerve to reanimate certain functions of the face. And in this case, masseter facial nerve transfers, hypoglossal facial nerve transfers, even cross-face nerve grafts from the contralateral side have been performed with varying levels of success. Whereas in the late case, we are not relying on reinnervation to occur, and a gracilis or temporalis muscle, being the most common type of muscle transfer, is used to basically supersede the actual muscles that have been denervated. Static slings I only mention here because they are not largely practiced in my particular patient population because of their poor cosmetic outcome, but things such as eyelid and gold weights are static options that address lag ophthalmos, but they do not necessarily, and they are good options, but I do not necessarily employ them in places that I can use a dynamic option, such as in the smile or lip refunctioning. In nerve transfers, again, in the early setting, we can use these various options, and it really is an interesting and newer option, relatively speaking, than the muscle transfers, in the sense that the nearby functioning cranial nerves are transferred into the non-functioning facial nerve to reinnervate functions that have been lost. And it's really important to properly analyze the paralyzed face. I break down the paralyzed face into thirds, as in many things in plastic surgery. We like to think of the face or the body in thirds and decide to intervene based on evaluations within these areas. So in the upper area, we're dealing with the forehead or brow elevation. Middle portion are the eyes or eye closure. And in the lower portion or the lower third of the face, we're really dealing with lip animation, smiling, articulation, and closure of the lips. And of course, assessing the face at rest and with animation is a unique part of nerve surgery, where we really need to see what's happening with in both those settings. So in the upper third of the face, we're really looking at cosmetic problems mostly. The lack of brow elevation really results in flattening of the forehead and loss of wrinkles, but it also does get noticed with various spontaneous animations or postures, and it can be a source of psychological stress. Brow ptosis, functionally speaking, can result in a secondary upper eyelid ptosis, which can in turn obstruct the visual field, and that is a problem that will need to be corrected. In the middle third of the face, again, we're dealing with eye closure. Poor eye closure can lead to scleral show, and in a very severe setting, it can occur, there can be corneal scarring or keratitis, and as well as other symptoms, including epiphora from lack of the normal tear drainage and chemosis of the conjunctiva. In the lower third of the face, the most obvious problem is smile asymmetry. We get a shift of the upper lip philtrum and oral commissure to the non-paralyzed side. We lack a nasolabial fold on the paralyzed side. The nasal base gets deviated. as well to the non-paralyzed side, and the unopposed lower lip depressor activity on the non-paralyzed side can be quite obvious and imbalancing to the face. Interestingly, along those lines, there's a compensatory speech pattern that results from shifting of the function towards the non-paralyzed side. In other words, patients tend to talk or articulate with the corners of their mouths that are working, as opposed to having a more symmetric basis to achieve a proper speech articulation, and this could be a very challenging problem to fix. Propelling food is a function of the buccinator muscle, also a muscle supplied by the facial nerve, and in patients who do not have a functioning facial nerve, the buccinator is impaired and food gets trapped in the cheek. These patients frequently need to use their fingers to manipulate food boluses into the back of the throat for swallowing. Along those lines, this does result in pooling of saliva and drooling that can occur on that side. Here's an example of a nerve transfer in the early stage. This is a patient who underwent a temporal Ewing sarcoma excision and had some level of facial nerve recovery, but not complete. He has some eye closure, some nasolabial fold, and no lower lip. We decided to go with a masseter to facial nerve transfer. And here, showing him 2 years post-op, we're seeing a very nice result whereby we have good elevation and deepening of the nasal fold. We even see some return of lower lip depressor function, and better eye closure is happening as well. Here's another instance of a masseter facial nerve transfer in a 2-year-old with an idiopathic source of facial paralysis that failed to recover on its own after 6 months. We decided to do the facial nerve masseter facial nerve transfer. Here we're showing the operative picture. On the left is the facial nerve trunk from the stylomastoid foramen, which is then divided at this location and essentially loses all function or potential for function through those channels for the future. This is a sacrifice in this type of technique whereby the masseter nerve is tasked with reestablishing innervation to those facial muscles that have been denervated. And this is the nerve repair done. We're seeing the distal portion of the facial nerve trunks reflected superiorly, and the masseter nerve is reflected out of its pocket, and the repair is done outside. And this is what we see 3 months post-op. This patient was lost to follow-up, but we do see some very interesting and nice results at 3 months post-op even, where we're seeing deepening of the nasolabial fold, but we're in some level of elevation of the lower eyelid. There's still some weakness of the lower lip that we can tell by this picture. And it's unfortunate because I wish to have shown some more pictures and video of this particular patient who did very well. Now we're switching gears to the more late phase treatment options. We start to look at the thirds of the face once again in their entirety. We look at the upper third as a problem with brow elevation, and in this 7-year-old, we see a trauma patient with a frontalis nerve. Frontalis branch affected, and we have decided that he will require a brow elevation or a brow pexy procedure to relieve his upper eyelid ptosis. And in this case, we simply did the brow pexy without an upper eyelid ptosis correction, and we're seeing lasting results even 1 year post-op. We also talk about briefly symmetry procedures. Things such as denervating or stripping the muscle on the normal active side can help balance the face and functions better. And in this case, we're showing a frontalis resection. About a 1 to 2 inch width of frontalis is removed completely from the non-paralyzed side to help reestablish upper brow symmetry. Now, going to the middle third of the face, we really deal with lagophthalmos, which really constitutes upper and lower eyelid problems. In the upper eyelid, we see a retraction of the upper eyelid, which requires weighing down typically to help assist dropping of the eyelid and protection of the eye itself. The upper eyelid will then be treated usually with gold or platinum weights. Sometimes springs can be placed, as well as fascia interpositional fascia grafts into the levator mechanism to help lengthen this process. In the lower eyelid, this is demonstrating my preferred technique of a lower eyelid palmaris longus tendon sling. The tendon is anchored on the medial canthus as well as the position on the superolateral orbital rim superior to the lateral canthal insertion site to help elevate the lower eyelid completely. Other things have been performed, such as tarsorrhaphy and wedge resections of the lower eyelid, as well as mid-face lift, which are effective in elevating the position of the lower eyelid. But again, my preferred technique, given the tenacity of lower eyelid malposition in facial paralysis, is the palmaris longus tendon sling. And here's an example of that. This is a patient with facial paralysis that underwent simultaneous upper eyelid platinum weight insertion and lower eyelid tendon sling, as described. And here she is 9 months post-op. The lower eyelid position is adequate, and with eye closure, we're seeing near complete closure of the eyelid with no significant levels of ptosis to speak of. Now, switching gears to the lower third of the face, we're really talking about smiling in many cases. We're really trying to reestablish smile for very obvious reasons related to psychosocial development and also secondary benefits of speech improvement and swallowing improvement. And here we're seeing the Rubin classification that deals with various smiles that are possible and characterize the human experience. And here we're seeing two separate types of smiling. Again, symmetry correction is a big part of facial paralysis surgery. We want to correct the symmetry in a similar way that we do the frontalis muscle correction. These are static procedures where a myectomy or a denervation is performed to help block a function that is not necessary in terms of global facial movement, but does create a certain level of distraction. And this is an intra-op picture of the lower lip depressor muscles isolated through a transbuccal incision. The vessel loop is surrounding the mental nerve, as you can see here, and where the dissection goes all the way down to the subcutaneous tissues, which you can see here in the center picture. And these are some post-op results. The lower third of the face, we also talk about placement of the Gracilis free flap muscle. There is a one-stage versus a two-stage option whereby a free Gracilis muscle is transferred to the face itself. Now, there's various advantages and disadvantages to a two-stage versus a one-stage, and we need to really quantify those in terms of counseling our patients. The advantages of a two-stage approach are obviously a spontaneous smile, whereby the normal cranial nerve function is borrowed from the functioning normal side of the face. The disadvantages are that there are two surgeries and it takes longer to achieve facial movement. In addition, the strength of contraction typically is weaker than in other options whereby the ipsilateral masseter nerve or an ipsilateral functioning cranial nerve is used. Here it is in the intra-op picture. Here's a patient who's undergoing a cross-face nerve graft. The cross-face nerve graft is harvested. The branch in the normal side of the face is isolated, and it is shown here in its contracted state. And then the muscle is transferred as well in a second stage, approximately 9 to 12 months later. Here's the nice vascularized portion of the gracilis muscle that will become the innervated portion. This is the ex vivo picture with it stimulated, and then the inset here. And this is a typical sort of a result excuse me, of this type of procedure where the patient does achieve movement, which if you look at the oral commissures only, this is actually quite good movement. However, there's other deficiencies. The upper lip does not elevate as well. There's a lack of a nasolabial fold formation. There's unusual dimpling. There's also a bulge here. All of these detract from the overall results, in my opinion. Here's another result. Again, a slightly better result where we're seeing a good level of animation and symmetry achieved. But why would you do a one-stage then over a two-stage in these settings? Well, again, the reverse is true. There's quicker time to animation. We're really dealing with one surgery versus two, and the contraction is stronger. The disadvantages is that this is largely non-spontaneous function because we're typically using the fifth cranial nerve in the biting function, which is not always intuitive in patients and requires extensive rehabilitation. And the one stage really uses the masseter nerve, which is a branch of the trigeminal third division, as you can see here. And this is an example of the gracilis muscle attached to the ipsilateral masseter nerve. Once again, a very good result, and overall, if you look at the central portion of the face, this is quite good, but there's the other deficiencies that are noted. The excessive bulge in the cheek and the unusual dimpling is also seen. On an upside, we do see just by inserting a piece of active muscle in the cheek, we're getting a rise in the lower eyelid position, and in essence, treating the lower eyelid malposition without any further eyelid procedures. Here's an example of a Mobius syndrome patient where sequential gracilis muscles were used to insert into the face, and we can see that here. In this patient, once again, this highlights the bulge in the cheeks, which is an unfavorable result in some cosmetic sense. In the lower third of the face, we really also want to include the temporalis muscle. The temporalis muscle, as described by Gillies, was a turnover flap that extended over the zygomatic arch and towards the oral commissure with sometimes an interpositional fascia glottograph. However, the procedure, the lengthening temporalis myoplasty, as described by Labbe, is a very intriguing option that can sometimes help a patient without producing the excessive bulge and in an orthograde fashion, utilizing the deep buccal fat pad space. And here it is in practice. The temporalis has been mobilized to this upper right-hand corner. It is once again anchored at the expense of the posterior segment to achieve lengthening at the nasolabial fold and the tendon insertion site. Here the tendon is grasped along with the attached coronoid process, and it is then stripped of the coronoid process and inset into the nasolabial fold in the desired position. And this is what we see postoperatively. Here she is at 2 weeks, and at 8 weeks with smiling, and then at 2 years with a slight revision that was performed to help achieve a greater and more symmetric smile. And here's this patient with activation of her smile. And you can see she's able to produce a nice smile with fairly good symmetry, even early on. Here's another example of a patient who underwent several procedures, including a lower lip depressor myectomy, as well as a paralyzed side temporalis procedure. And you can see even after one surgery, there's fairly excellent symmetry, both at rest and with animation achieved. To be critical, there's still some temporal hollowing in these early patients that were performed, which is somewhat disconcerting and will need to be addressed. Another result of a patient with a temporalis procedure that was performed, and you can see here the results of this patient.
Can you say puppy?
And with speech animation.
Perfect.
Perfect.
Birth Elliot, big, nice big one. Nice, very good.
So you can see that temporalis is very controllable, and a lot of patients and a lot of the children specifically are very adept in adapting to the new way of functioning of the face. Here's a patient with Mobius syndrome with complete inability to move the face, and a simultaneous bilateral lengthening temporalis myoplasty is performed in this patient. Here you can see him at 10 months post-op. He's got very good control. He's exaggerating his bite to activate his smile, but he's very happy by the overall results, and he no longer gets teased at school, which is a plus. So why do the temporalis over the gracilis or vice versa? Well, let's look at it side by side. The number of surgeries required is 1 versus anywhere between 1 and 2 for the gracilis, depending on whether or not it's a 1 or 2 stage procedure. The spontaneity of the smile is a real point of contention. In the temporalis, you do not see the ability to have a spontaneous smile, where you do see the option via a cross-face nerve graft of having this in the gracilis. Additional cheek bulk is another advantage to the temporalis column, which is completely absent, whereas there's no real way of completely obviating or eliminating the possibility of facial bulk. and the Gracilis option. The predictability of the smile anatomy. Now, this is a very interesting feature, I think, with the temporalis. During the temporalis myoplasty, there's the neurovascular bundle is not disconnected. Thereby, stimulating the temporalis muscle does result in contraction of the oral commissure after insertion of the temporalis tendon. And by way of stimulating the muscle, we are able to readjust the insertion site. Something this is not completely known about Gracilis. It is largely not practiced in the Gracilis surgeries because of the delicacy of the microsurgery involved. The onset to smiling is much quicker in temporalis cases, and the nasolabial fold placement is much more accurate as well. So in looking at our results with our early experience with lengthening temporalis myoplasty, we looked at a 2-year period where 14 children had lengthening myoplasties performed, and we saw that the operative times were markedly shorter than the Gracilis options, and no patients required an ICU stay. There was improved time to reanimation and overall satisfaction with that procedure. The drawbacks, however, were quite significant as well, though. There's a steep learning curve. The anatomy is not very obvious of the temporalis, even with anatomical studies. Some of them are somewhat incomplete or incorrect in terms of identifying the layers of the temporalis muscle, and even more importantly, the various insertions from nearby adjacent muscles such as the masseter and the pterygoid musculature. We also saw that there was a relatively high revision rate, specifically related to avulsion of the tendon insertion and sometimes adhesions within the tendon's tunnel. And these required a revision through the nasolabial fold, a very simple revision that took approximately 2 hours, and in adults can be done with local and perhaps some sedation. But in 2/3 of our patients, we did require some level of revision for this problem, and that may be related to the constant innervation and spasticity of the muscle after movement, and perhaps compounded by the fact that there may be a normal functioning contralateral facial nerve which stretches the insertion site even further. We did see temporal hollowing in the early patients in that series, but this did improve over time. So to go over a quick summary of this talk, we really need to define whether facial paralysis is occurring in the early or the late phases. And we want to base our treatment options on the timing of this paralysis. The presence of neuromuscular end plates is a very important feature and factor in the success of an early nerve transfer. Dynamic options are always a superior option in my book over static options. It should be practiced whenever possible, except in patients that do not have the dynamic options available or have morbidities that preclude them from getting these types of procedures. And I want to conclude by saying that the approach to facial paralysis is a comprehensive one. We shouldn't take the smile in its isolation or the eyes in their isolation. It's really important to break down the facial nerve function into the thirds of the face that I've described, and then to understand how one reconstruction can impact the adjacent third of the face, for example. And these are very important concepts to keep in mind when dealing with facial paralysis patients and initiating treatment. So I want to thank everyone again for listening to my talk, and I will open this up to questions. If you need any further information, the websites are up on the screen for your information. Thank you.